So we are now in the second joint session with the European Association of Percutaneous Cardiac Interventions and Bulgarian Interventional Society. This session is dedicated about treatment of cardiogenic shock, which is one of the most devastating complications which we have to deal on. And I would like to invite Professor Kefo to give her talk about the current treatment approach in 2023.
So first of all, I would like to thank all the organization committee for this invitation to have thought about to have a session together with the EAPCI. I really enjoyed the discussion, the first part. And now we enter in one of the fields that needs still a lot of discussion and work to be done. I start with this slide that I also showed in other meetings. The fact that despite neutral trials, we did have at European Society of Cardiology the presentation of SCLS shock, that was the randomized clinical trial that was hypothesizing that the use of ECMO in all class of shock could have lower 30-day mortality. Actually, the trial was neutral. But after that, that was this very interesting Twitter. Will neutral result of this trial change your practice? And this is very interesting, I say, because as president-elect of EAPCI, you have to listen to the community. 65% of the person, clearly this is Twitter community, so it's a representation of all EAPCI, said no. So why, despite the natural result of trial, the community still believe that indeed we need to use MCS in real world? So how effectively are we targeting the pathogenesis of MCS with this kind of devices? And by the way, are we adequately designing trials for MCS in acute MI cardiogenic shock? It's not moving. Okay, now it goes. And it was said at the beginning that this is one of the most devastating mode of presentation of acute MI. We are still stuck, you see, from 2005 to 2017, mortality has almost been always the same, around 60%. And we are not improving this, despite the usage of devices to support the mechanical circulatory support devices. And again, very interesting that despite the negative results of the IBP shock, still the majority of the community is using intra-aortic balloon pump to support patients presenting with the acute MI cardiogenic shock. The whole point is how we intend the management of an acute MI cardiogenic shock. Because in reality, we should move from one device approach to a multi-strategic approach with an in-depth characterization and patient-tailored approach. This regards the prompt diagnosis of cardiogenic shock and degree of severity, the phenotyping of cardiogenic shock and evaluation of comorbidities, and the management of selected treatment strategy. Let's start from prompt diagnosis of cardiogenic shock and degree of severity. Cardiogenic shock is an heterogeneous clinical scenario, and this is the SCAI classification, which is the most widely used in order to define cardiogenic shock. You have a patient at risk, which means a patient that is presenting with a large acute MI, usually an anterior MI, that theoretically can expose him to the risk to develop a cardiogenic shock. You have cardiogenic shock at the beginning, which means that a patient has some clinical evidence of relative hypotension or tachycardia without hypoperfusion. Then you have the classical cardiogenic shock. So the patient is in cardiogenic shock and needs inotropes or mechanical support devices. Then you have the D deteriorating, where indeed the patient is not responding to therapies. And extremis is really what is called cardiometabolic stage of shock, where mostly whatever you are doing is quite futile. So clearly, if you have a trial that is including patients from C to E, is including such an heterogeneous class of patients that it's very difficult to demonstrate that one device actually can decrease mortality at 30 days. And the other point, as we said, it's heterogeneous, and by the way, the mortality is different. This is taking into account the baseline SCAI stage and the different etiology. Acute MI cardiogenic shock has an higher mortality as compared with heart failure cardiogenic shock, and the mortality, as you can see, is much higher if the patient is presenting with DAD. And by the way, it's even higher if the patient is escalating from a cardiogenic shock C to a cardiogenic shock D during the hospital stay, because there is a lack of prompt diagnosis of cardiogenic shock and management of the patient. Phenotyping of cardiogenic shock and evaluating comorbidities. This is taken for a very nice publication of last year in Circulation that show you how indeed, according to the phenotype of the patient and the clinical picture, the decision-making regarding the MCS to use is different. So consider the phenotype of cardiogenic shock. Will the patient need left ventricular unloading? And consider, in case you are deciding to use an MCS, preemptive placement over bailout. And consider the clinical picture, because clearly one thing is a left ventricular predominantly cardiogenic shock that is very well defined by parameters as PCWP, and in this case, the device to use would be Impella CP 5 or 5.5, tandem heart, or central temporary LVAD. And indeed, if you have a biventricular, which means you have high PCWP, but also high pressure in the right atrium and PAPI, in this case, one device is not enough. It can be via ECMO or a Bipella. And then you have the right ventricular failure, and in this case, the device to use can be Impella RP, Protect Duo, or ECMO. And this is coming again from, indeed, from an EAPCI CVC consensus document on MCS, again, setting the standard, which are the patients in whom we should think about mechanical support. And this task force consider patients SCAI C and D with failure to respond to initial therapy according to specific parameters that you have to take into account when you decide to implant devices. What about, indeed, recommendation? This is 2021 recommendation on acute and chronic heart failure, and they were giving short-term MCS in patients with cardiogenic shock as a bridge to recovery or bridge to indeed VAD or bridge to transplantation, and 2A level of evidence B. But what happened then, in the latest guidelines of SCS, there was a downgrading to 2BC, actually without any further data. This was done by vote during the ESC guidelines committee, just to show you how the community, by the way, is not in the same direction. But are we talking about different devices? We are talking about intra-aortic balloon pump. We said there is not an indication, providing only 0.5 liter minutus. Impella, indeed, providing 2.5 is no longer available in Europe, so from 4 to 5.5 liter minutus. And it's providing left ventricular unloading, but the problem is the sheath size. And indeed, there is via ECMO for biventricular support, very high flow rate, but is not unloading the left ventricle. And what about the pathophysiology of shock hemodynamic response to MCS? The first is the normal PV loop and PV loop in cardiogenic shock, and the slope EES shift with changes in contractility. In B, you see the PV loop in via ECMO supported cardiogenic shock. So the PV loop become narrower with an increase of ADPVR, and indeed with Impella, there is this triangular shape with loss of a normalized volumetric period, reduced ADPVR, and conversion of the typical PV loop to a triangular shape. That's important. When we are using our device, we have to know which is the hemodynamic response that we are going to have from each individual device we are using. And then management of selected strategy. As I was saying before, we did this in 2021. We published this joint EAPCI CVC expert consensus document that I was chairing together with Susanna Price from ACVC. And again, a task force of experts came out with indication. These are not recommendations. Intra-aortic balloon pump routine use is not recommended, maybe used in patients with mechanical complication post-TAMI or in non-acute MI-related cardiogenic shock. Why that? Because the EABP shock trial was not analyzing those patients. Axial flow pump as Impella may be used as short-term therapy in stage C and D, but in patients where there is a potential reversible underlying cause or as a bridge to transplant or to bad candidates. And via ECMO in that time, prior indeed to the publication of SLS shock in stage C, D, A, E in patients with combined respiratory insufficiency or use in refractory cardiac arrest, and biventricular CS via ECMO or ECPella. And then SLS shock trial. As I said, this was presented at the European Society of Cardiology. And as most of you know, this is a neutral trial. The hypothesis of the study was to have a mortality of 25% with ECMO that I found very optimistic, considering that they were enrolling from C to E, and they had 77% presenting with the cardiac arrest. However, the trial was negative in the primary endpoint. But again, let's see how the treatment was done. There was a 9% of patients that died, even being assigned to SCLS, waiting for SAS to be implanted. And prior to revascularization, only in 21%. So mostly the ECMO was implanted during the procedure or after the revascularization. And indeed, in the control group, you had 12.5% of the patients not randomized to ECMO receiving ECMO, and indeed 15.4% in the control group receiving Impella. So almost 26% in the control group received at least one MCS. And what about the unloading? We showed which is the effect of ECMO and why you need to unload mechanically the left ventricle. Despite it was described in the protocol, only 5.8% of these patients had mechanical unloading during ECMO implantation. And that's very important. This is a very nice recent study published in JACC Heart Failure 2023 that is demonstrating, by the way, the left ventricular unloading until 2 hours after via ECMO is going to reduce of 36% 30-day mortality without increase in likelihood of complication and gradually increasing mortality risk with every hour of delay of active mechanical LV unloading. So considering that 5.6% in the ECMO group receiving indeed mechanical LV unloading, we can also better interpret the result of that study. Clearly on the Impella side, we don't have randomized clinical trial. Danger Shock has finished the enrollment finally. It took a lot of time. It is the randomized clinical trial of acute MI cardiogenic shock that is randomized with Impella control group, and primary endpoint again is mortality at, in this case, not 30 days, but 180 days. And let's see which are going to be the result. But in the meantime, we have a lot of data, very debating and very controversy, especially the data from US are not very optimistic, I would say. Mostly they are taken to this widespread use of the device without an appropriate training of the operator and the center, and very diverse indication. This is indeed our national study. This is, by the way, a study that was supported by GISEM, the Italian Society of Interventional Cardiologists. I was the PI. 406 patients were involved. Mostly they were, the indication to have an Impella implanted was cardiogenic shock. And one of the results that came from our study is the importance when you are going to use the device in acute MI cardiogenic shock to insert, to first get a good hemodynamic stabilization of the patient before doing the primary PCI. So if you are using this, use at the beginning of this procedure. And this kind of result was quite clear in all the literature that is using this device in cardiogenic shock. However, this device have complications. This has to be taken into account. And again, this is a figure taken from our EAPCI CVC consensus document, and mostly complications are access related. So there is work to be done. Access, when you are going to use these large bone access devices, cannot be only angio-guided. You have to learn how to puncture the femoral access, how we learn with structural intervention. So the importance of echo-guided puncture. Now you have the single access technology for impella preclosure. Positioning, that's another important point. Very few people discuss on that. We published about malrotation of impella, for example. So echo guidance and check, because there is the possibility on the monitor aortic and LV curves. Management. This device, for example, I'm talking about impella, give you different level of support. You have to learn how to use it. So it's not just implanting, but having the right team on your side, understanding the physiopathology and the support. Anticoagulation, heparin, we are using, by the way, bivalirudin in my center, and weaning, escalation and escalation, and then consider again that this patient or are going to recover or have to be bridged to other kind of therapy that can be VAD or transplantation. And this is, I think, a very interesting slides because show you that actually when you are using the best practice protocols, and we're talking about the usage of impella, which means identify cardiogenic shock early and use impella before primary PCI in cardiogenic shock, aggressive downtitration of inotropes, identify RV dysfunction early and support, identify inadequate LV support and escalate a systemic use of RH to guide therapy, you're going to have 82% of survival of patient in acute MI and cardiogenic shock as compared with all the prior experience where indeed, as I showed from the beginning, the mortality was 50%. So it's not the device itself, but it's a strategy, multi-strategy involving different people in your team. And again, the shock team, because it's not only about interventional cardiology. It's implanting an impella, if you are, by the way, doing structural or you're doing complex PCI is quite straightforward. But you need people to help you in dealing with the device in the cardiogenic shock, in the intensive unit care. You need cardiac anesthesiologists, intensivists, perfusionists, nurse, vascular surgeon, because it's a team approach. And the importance of hub-spoke network with a standardized system of care network for cardiogenic shock. This is taken from a publication of last year from US. They demonstrated that when they started to have a system, an algorithm of collaboration, early recognition and transfer of patient between hub and spoke, they were going to reduce mortality rate of this patient. So this is the direction that actually we have to go, an hub and spoke network. And we did for ST elevation MI, we should do the same for acute MI cardiogenic shock, taking into account that it's not only interventional cardiologists, but this is a multidisciplinary, multi-strategic approach. So in conclusion, the heart is not only the left ventricle. Cardiogenic shock is not only about the heart, and you have to consider extreme cardiogenic shock. And dealing with this kind of patient, in order to have your algorithm, you have to take into account shock severity and adequate classification, the phenotype in the clinical picture, the management, which is multidisciplinary with a shock team and a shock network. High expertise for optimal MCS outcome. We saw that the complications mostly are due not only to the comorbidities and the condition of the patient, but also to the expertise, the training of the operator. And that's my personal thought, the paradigm shift in clinical trials from one device and one strategy to a multi-strategic approach. One device does not fit all, and one device might not be enough. Thanks for your attention.
Well, that was a great talk and summary of the state of the art, actually. Maybe it would be useful just Professor Karamfilov to give his talk, and then we have enough time, maybe around 20 minutes, just to discuss what we can do in practice.
Okay, I'm supposed to give the management of cardiogenic shock in Bulgaria, the Bulgarian perspective, so I hope I can manage. But you should consider it as my personal view of the story. Some facts that are well familiar for most of the people, but I think that they're relevant to the talk. Some facts for Bulgarian overview. The population of Bulgaria is decreasing in a very fast pace, and the age distribution is quite unfavorable. We have more old people than young ones. As you can see that we have negative birth rate of 1.31%. So it's something that unfortunately needs to be changed. On the other hand, we are among the poorest nations in European Union. So it gives some idea why we cannot benefit from the most advanced of the machines and drugs that are largely available in Europe. And finally, this is the final cause of everything, from the prophylaxis and from prevention to the treatment of the worst cases, comes with the shortest mean life age in whole Europe. We live like 10 years less than mean European citizen. Okay. It's no surprise that 2/3 of the death rate by cause is cardiovascular disease. So this gives us the huge responsibility of what we are doing. So just to illustrate our perspective, I'm going to give a few words about the patient. It's an old patient coming to our emergency room with complaints of extreme dyspnea and shortness of breath and excessive sweating. He was agitated upon presentation, confused, and we were not able to have a good talk with him. You can appreciate the ECG, the poor general condition, elevated heart rate, low blood pressure, respiratory rate above 35 per minute, and low saturation upon admission. You can appreciate the changes in the chest X-ray according to the lung system and enlarged heart. On the right side, you see the lab, which is consistent with myocardial ischemia. This is the echo examination, which is quite evident, severe mitral regurgitation with low ejection fraction. According to all the criteria, to different trials, we have a patient in poor condition with shock, low blood pressure, elevated heart rate, and respiratory failure. By no exception, this patient is in general population of patients coming to our room, emergency room, with complicated myocardial infarction. So it's been taught about the protocol of management. We have all the criteria, history, ECG, echo, chest X, everything was performed. We have confirmed cardiogenic shock, and then 2 arms of action for ACS. These are the goals that we needed to achieve in order to treat the shock in the best possible way. Revascularize the patient with establishment of TIMI-3 blood flow, which could be performed by PCI, and then consecutive medical treatment. Then to achieve the proper afterward with specific criteria for mean arterial pressure, systemic resistance, vascular resistance, etc., then we need to treat the preload. If it's necessary to increase it with crystalloids or to decrease it with diuresis. Then to achieve the best possible contractility, either by drugs or machines, and to provide good heart rate. I'm not going to go into details. It's very well familiar facts. What are the drugs that we're using in treatment of cardiogenic shock in terms of increasing the pump function? This is the protocol that has been shown. It's been told about the different types of mechanic circulatory system devices, and they are all backed up with specific trials showing our confidence of using them in patients. In Bulgaria, we are largely using intra-aortic balloon pump, and we are not, we're missing Impel and other devices. There are a couple of slides to show at the end the difference in between the best practice that were shown previously and our scenario. This is the trials that are backing up the usage of impeller devices and ECMO, which is presented in some of our centers with cardiosurgery mainly. Okay, so these are the differences in between the indications and the advantages and disadvantages, which I'm not going to stop by. So from our perspective, these are the differences in between what's shown in the guidelines and what is the current real situation in the country. In terms of medical treatment, we are very consistent with the best practices. We have all the antiplatelets except the cangrelor in the country. All the anticoagulants, statins, inotropes, and vasopressors are present largely in the country. In terms of hemodialysis centers, they are based mainly in the two great hospitals. In terms of other very important for treatment of cardiogenic shock prerequisites, we have very large and largely distributed network of PCI centers in terms of treating the myocardial infarctions. There are very few places that are not well covered by them. So in that scenario, we are happy to see it. In terms of cardiosurgery centers, there are few in the country, and still there are places that take more than usual time to reach by. I thought that Impel is not available in the country, and ECMO is available only in some centers, extremely largely used for treatment of shock patients, and that's valuable for tandem heart. So one of the most important problems from my point of view is that there is no good financial support for treatment of that patients. Whenever we are speaking about patients in cardiology hospitals, cardiology clinics, it's not been excessively covered but by health insurance fund. The balloon contrapulsation is not being covered, and the hospital stay, all the drugs and machineries are predominantly covered by the hospital or by the clinic itself. So back to the patient, of course, according to the protocols, we initiated infusion with furosemide, dopamine, and dobutamine. The patient had been intubated and mechanically ventilated. Put nasogastric intubation, give the DAPT and atorvastatin, and enter the cath lab. You see the hemodynamics upon arrival into the cath lab. This is the angiography. You may appreciate the diffuse changes in right coronary artery, which is chronically occluded. Same valid for circumflex and diffuse changes of LAD. You can see it in another view. By the way, the arteries are contracting. You can appreciate the very severely depressed ejection fraction. Unfortunately, it's not the good exit and good practice. Whenever a patient entered the coronary angiography, he got idioventricular rhythm and blood pressure severely dropped. We began CPR, of course, infusion of inotropic at large doses, but unfortunately the patient didn't make it. So in conclusion, I think from the previous lecture and from my short talk, we are all very confident that cardiogenic shock is rare, but very deathful disease with high mortality. And of course, most common cause of the cardiogenic shock is myocardial infarction. We need to act fast. We have to use all the possibilities in terms of mechanical support, drugs, and intubation in order to restore the vital signs. And something from our point of view is that discrepancies between recommendation and real clinical practice in terms of financial, in terms of availability of devices must be considered whenever we are treating the patient. Thank you.
Well, you should be brave to show such type of case on the meeting, because you know, the usual practice is to demonstrate the glorious cases, but this is part of our practice. Unfortunately, in our country, we have relatively good coverage, financial coverage for treatment of primary PCI, but not any about the complications in acute MI, for the cardiogenic shock, even for the IBPA, we have to pay from the budget of the hospital if we want to place a balloon pump or ECMO, which is very, very rare. In very few occasions, still in Pele do not have reimbursement, and that's all what we have. We have medicines, balloon pump, and but I would like to ask Professor Kiev about the last trials. Do you think that the negative, not negative, but let's say neutral, yes, okay, let's don't, yes, neutral, to be polite, neutral results from studies are because that in randomization process, the patients which are included are in different hemodynamic sky stages. And if you, let's say, randomize patient in stage B, B to C, it's different than to randomize patient from stage C, D. And probably if there is, because in earlier phases of stages of shock, I'm really convinced that the mechanical support will work well. But in later stages in shock, where the metabolic changes are advancing, nothing will help.
So we are talking about SELS shock, just to mention, because sometimes there is a lot of confusion also in the communication of result of trials. That's why I showed different MCS. We have different MCS. ECMO is one of the MCS, and we knew from the beginning that, for example, this should not be indicated in cardiogenic shock C. I mean, we do have all. The largest shock center in Italy, and I'm very lucky. I have the possibility to use all. I never use an ECMO for SCI C. Also, there is no indication, honestly. And on the opposite side, I would not use an ECMO, or maybe unless, you know, it's a very young patient, in a patient that arrested more than 20 minutes out of hospital that were included in that trial. So the neutrality of ACLS shock, in my opinion, is due first to the patient selection. They allowed to be in the trial patient in cardiogenic shock C, so not so much disease to need an ECMO, or on the opposite, in shock E, with a cardiac arrest in 77% or more than 20 minutes, which means not ventricular fibrillation, but electromechanical dissociation. So they were or not too much sick or too sick to benefit from ECMO itself, and that was the first big problem of the trial. Second big problem was the strategy management, as I showed, because again, there was a 9% of patients randomized that actually never got ECMO. And when they got the ECMO, only 20% at the beginning. So mostly the patients were collapsing in the cath lab and they had to rush to implant an ECMO. Are we expecting this patient to go well? No. They never did unloading of the left ventricle. Again, you need to unload the left ventricle. You can unload with the impeller, you can unload with intra-aortic balloon pump, whenever you want to unload septostomy someone, but you need to unload, otherwise there is an increase of the afterload. And this is going to impact on the recovery of the left ventricle. So the problem of that trial was first, inclusion criteria, second, management of the patient. And by the way, in that trial, if you see the recruitment per center, there were, if all the center included the patient at the same time, which we know is not true, 3 patients per year. So do you think it is an expert shock center, a center that have 3 patients in cardiogenic shock per year? No. So that is the clear, I think, evidence that when we are designing clinical trial, we have to be more meticulous in patient selection, center selection, and by the way, also the endpoint, because I don't believe the 30-day mortality is an appropriate endpoint, should be mostly LV recovery or bridge to other therapy. So that's the reason of the neutrality of that trial. And this is not what we are doing in our common practice. Because, for example, that patient, if it came to my center, I would first implant an impeller CP and then revascularize. Because we know that this patient, just by angiography, can collapse. And if you implant an intra-aortic balloon pump in a patient arrested, it's not going anywhere. In that case, you have to put in ECMO.
I think that this is a very important message which should be stated very clearly, that the mechanical support is the first. This is my personal view. This is what I'm doing. The mechanical support first, and then angio, PCI, whatever you do, because the common practice is reverse, actually. This is in reality. The first, what happens usually is that to do angio, and then to see the anatomy, and then decide what to do. But most of the cases after angio is too late.
Stabilize first. That's what intensivists teach us.
Yes.
I mean, I work a lot with our intensivists because being a shock center, you have to work with them. And first is hemodynamic stabilization of the patient, first, and then anything else. Because you cannot, by the way, that was not an ST elevation MI, that was most probably a patient with heart failure because had that huge myocardial regurgitation. Maybe he didn't know, but it was already a chronic heart failure that had acutization because there was what is called global ischemia, because it had 2 CTO and suboccluded LAD. But especially in those cases, first is hemodynamic stabilization, because without hemodynamic stabilization, you're not getting out of that situation.
Yes, I think that we have.
There is a place for balloon pump.
So balloon pump, the current place, because we don't have a study, is non-ischemic cardiogenic shock. I mean, the ABP shock was negative, but also physiopathologically, if you give only 0.5 liter minutes in important, significant cardiogenic shock, clearly physiopathologically you are not going to support appropriately the patient. There is ongoing a randomized clinical trial, by the way, in Italy called ALT-SHOCK, which is in non-ischemic cardiogenic shock. I mean, let's see the result. I have to say that the intensivists are very on that because they say that when you have acutization of a chronic heart failure, in their opinion, also that 0.5 liter minutes might help. So let's see the result of that trial. And also in the recommendation, you know, it's not recommended. By the way, it's a class 3. So it's contraindicated to use unless there is a mechanical complication or unless there is a non-ischemic cardiogenic shock. But I can understand in countries where actually you don't have anything, I can understand. I mean, I would mostly push the authorities indeed to think about other kind of devices, because if you are not reimbursed for intra-aortic balloon pump, so you are not getting money, at that point, let's consider indeed to have a more effective device. But I know it's very complicated, and all these insurance is very, very complicated. We took a long time, but in Italy, actually, we do have a specific code, and they give us another kind of reimbursement for cardiogenic shock plus, for example, Impella or ECMO. It's a completely different reimbursement.
Actually, we have reimbursement for a lot of expensive therapies, but not for really, and for the therapies of diseases which are, let's say, doubtful about the results, but we don't have the reimbursement for balloon pump. But this is another issue. Local. Yes, Vasco?
I have a question. Actually, the problem is that some patients arrive in a cath lab not exactly in shock state. They still have some pressure and some perfusion, and they develop a shock during the intervention. So in this so-called, if you have huge acute MI, so what do? We are doing hemo before we open the artery. We open the artery, then we do a hemodynamics. Or how we decide which patient to support before the PCI?
So this is a long discussion I do every day with my intensivists, and they taught me something, that pressure is not a measure of cardiogenic shock, and I learned that. Because I think that patient was in cardiogenic shock. He had pulmonary edema at the radiography, it was clear. It was tachycardic. Then we can discuss, because also the sky shock mostly is on devices, it's not on physiopathology, if you think about the classification itself. So on that specific patient, considering also the mitral regurgitation, I would have implanted, because I have it available, the Impella to start with, to stabilize. Then regarding indeed the patient that come with a big acute myocardial acute anterior myocardial infarction, it's ongoing now, a randomized clinical trial, which is called DTU. I'm doing that trial. The trial is designed that you include patient with the anterior MI, not in cardiogenic shock C, and they are randomized to have 30 minutes of unloading with Impella before doing primary PCI versus primary PCI, and the primary endpoint is reduction in infarct size. I mean, as an interventional cardiology, to wait 30 minutes was really tough, I have to say, but we included the patient, and honestly, I have to say that in that 30 minutes, in our experience, we randomized 10 patients so far, and there is more than 400 patients randomized worldwide. There was relief for symptoms. They were relieving their symptoms, and there was also amelioration of the ST elevation. I mean, it's an hypothesis. If it's true, it's a paradigm shift change in our treatment. I mean, it's a randomized trial. Let's see the result. But I thought it was very, very fascinating because of what you were saying. How can you really predict a patient that really goes in cardiogenic shock C during the intervention? So the hypothesis is that indeed, if you unload that patient that is a large risk, you are going to decrease the infarct size. But again, it's ongoing. Let's see the result.
It is true that very often such patients deteriorate when the artery is opened. So it's probably, but I have the feeling that everything, because it's very not encouraging, let's say, to see the numbers of the shock and the mortality of these devices and resources that are sent. But as usual in medicine, in most instances, we have the devices, but it is a matter of organization and starting to apply the devices in a proper and systemic way, as it, for example, several steps in the treatment of myocardial infarction. And this is something that probably should be developed in general, and especially in our country.
I mean, I think it's very important, the slides that showed that it is when you actually use a best protocol in place. Again, it's not the device itself, but it's recognition of the cardiogenic shock stage, which is really complicated as cardiologists and interventional cardiologists, and act fast and be able also to change your strategy, because again, you can also escalate. When you implant a CP, you can go, if the patient is in intensive unit care, to a 5.0, 5.5, and then think about the exit strategy, because if they are not recovering, they can go to transplantation, they can go to VAD. So it's a change of mentality and application of protocols. In that case, for example, you went from that 50% that we are stuck from ages to 82% of survival, which what we are aiming to. But again, it means education of us as interventional cardiologists, of our intensivists, and all the team in the intensive unit care, because the nurse, perfusionists, they have to be educated to this management, and only in that case you can get to have the results that are in those series.
Do you think that the problem is actually early recognition of the stage? I mean, at the bedside of the patient, or when the patient is placed on the cath lab table? Because at the moment, if you take a lactate, for example, you need at least 15, 20, 30 minutes to receive the result. And if you...
Oh, really? No, we have as
a point of care?
Yes, lactates is immediate. When you do hemogas analysis, you have lactates. It's immediate, you have the lactates.
You see, so we don't have it in many places, let's say so. But anyway, I think that the lactate is a good point just to orient you where the patient is, because the patient could be with the good pressure, but with lactate 6 or 8. So that means that you should do something more than doing just inotropes or PCI, and to be very careful and very fast with the PCI.
Absolutely, it's early recognition, as early as possible, again, because it's not only the pressure, the parameter you have to take into account, also because maybe these patients were transported by other hospital, ambulance, and they are in adrenaline, so that pressure is not the real pressure of that patient. More heart rate. When you start to have a patient with 130 of heart rate, you know, start to think, and it's big anterior MI, it's getting to a cardiogenic shock C, I would say. Apart from and lactates, you have to have the possibility to have lactates ready. I mean, I would be interested in knowing in France, for example, do you have lactates in the emergency room? Yes, we do have. And I don't think it's an expensive tool, by the way, because it's done with hemogas analysis. Huh?
I think this is a question of thinking, not a question of money. Just.
Can I ask a question? Do you think that if we have implanted Impella, the result will be different?
You know, it's very easy to say, not being the CALAB with the patient, but I would have implanted an Impella to start with, as I said. I would have implanted an Impella with a CP in the lab and then do the angiography. And then, if not okay, because the patient arrested, ECMO. Because when it's cardiac arrest, honestly, the only thing is working to bring him to life is the ECMO. I mean, that's the indication for ECMO is refractory cardiac arrest.
Yes, the point here is that out of the Professor Carvanfiov Center, there is no other cardiology center with ECMO on site. Actually, their center is the only one who have an ECMO on site. This is another point, but well, we have a lot of things to do probably. Additionally, to improve the care for patients here.
But also, if you start, for example, with an Impella program, my personal suggestion, never start with the cardiogenic shock. Start with protective
Yes.
PCI. Because first you have to train your operators for the access, the management of the machine, whatever. Otherwise, then you have the downside of the technology because of acquisition of that technology. Start always the country. I mean, Italy started with RX PCI, and then we went to cardiogenic shock. And I think we have, after Germany, the country is using more this technology.
Okay. So, some comments or questions from the audience? Nobody? Okay, so thank you so much.